during Eid al-Adha many years ago, and I went to Al-Aqsa Mosque, and I would stop by the Palestinians who were outside. And they say, "You cannot go in, it's a holiday." I said, "No, I have come to pray." "Are you Muslim?" "Yes." They look at me, I'm wearing a shalwar and kameez, Pakistani clothes, okay? I look a little different. And they did not know how to prove, and he said, "Okay, recite Fatiha." So I recited Fatiha and says, "Ahlan wa sahlan, brother." So really, this is our Father does solve a lot of problems. So welcome to our Sunday lecture. Uh, Today I'm going to introduce briefly our speaker, but I want to tell you that next week is Dr. Munir Al-Khatib. All of you know him. He is a physician, but he exclusively practiced alternate medicine. And as you know, that alternate medicine has been talked about so much in recent years, whether it is beneficial or not. So he's going to give us a talk, and then on the 22nd, which is the following Sunday, Dr. Anjum will give his talk, which is a series that he's giving on the history of Islam. And then on the 29th, which is the last Sunday, I did not slot myself in, Salah Jabreen did, slot me in, and that is I will talk about what role the Silk Road has played in history, and particularly in the Eastern Chinese and between Europe and the East, the Silk Road. I was fortunate to travel on it in 2015 and 17. Yeah. So I will give a talk on that. We are in the process of putting schedule together for February and March, and I am pleased to tell you that whoever we ask, if they will give a talk in their field of interest, they have been more than willing to oblige us. That is the schedule for January, and the February schedule will be forthcoming. Now, we're talking about depression today, and depression, as all of us know, is much more common than we think. By some estimates, 20% of us, 2 out of 10 people, suffer from depression. We were just talking a while ago about Anthony Bourdain, the famous television star and foodie, that he committed suicide because of depression. There must be many other reasons for depression, but it is a hidden, under the surface malady which affects millions and millions of people. Our speaker this morning is Dr. Agha Shahid, a long-term member of the Islamic Center. He's a graduate of Dow Medical College in Pakistan. He has been practicing psychiatry in Toledo for over 40 years, and he has held the directorship of the Department of Psychiatry at Flower Hospital and perhaps at St. Charles Hospital. So please welcome Dr. Shahid. How much time? We adjourn this evening. Okay. No. Yeah, 40 minutes, and then we will have some time for some questions. And you can do it less than 40 minutes, there'll be more time for questions. Because at 1:30, we're going to push everybody for quiz. Okay. Thank you.
Thanks, Sanjay.
Thanks.
for giving me the opportunity.
This mic is working.
Yeah,
It needs to be closer.
needs to be close.
This one?
Yeah, no, the top one.
This is?
Just a little closer.
The speaker one. Yes. Thanks. I mean, I'm talking to my friends, so there's nothing that I'm going to say. As we said, that we are going to talk about something very common that we have. Okay. Yeah, I'm going to talk about, as Amjad mentioned, depression. It's a depression we use as a common word. Everybody get depressed. Okay, I am depressed. So the depression has been with human beings probably since human beings have been around. So one thing is, every day's depression is not the depression that we are going to talk today. And depression have been with us, as I said, since Hippocrates. He used the term melancholia when he was talking about imbalance in body fluids. There was a different concept. There were 4 body fluids. I'm not going to go into detail: yellow bile, black bile, and phlegm. And so that was the main thing of going on with the depression and melancholia. What I'm getting into is depression had been around. Hippocrates, who was what? About 400 or 300 BC. And afterward, the melancholia was the word which was used by Greeks, physicians, and melancholia, as I mentioned, was used for quite some time as a depression. The depression itself, if you just think for a flash of a second, depression is put down by force. So just think about the concept when we talk about depression. Put down by force. And this was in late French, 14th century language I'm using. And afterwards, depression, this put down by force as a disease, was lowering down the spirit. And so there, in mental illness, physical illness, when our ignorance has directed us in many different ways, and gradually we have come to this point, and I will gradually come to where we are today. So lowering down of the spirit, lowering down, that is the depression. But what we are going to talk today is the mood disorder from a medical point of view, not a depression. If you get, anybody can get down. God forbid, if somebody loses a close friend or a family member, they will get down. That is not the depression we are talking. That's a human reaction that is normal, that is there. But 10 to 20% of the population who suffers from depression, I'm going to talk about major depression, the melancholia when it changed to the major depression. One point is that 10 to 20% of the population, as Amjad mentioned, 10 to 20% suffers from it. Just to mention, we are all human beings. We can all have depression. Nobody is immune to that. Only, I don't want to say person, only robots don't get depressed. We human beings have emotions. So there's nothing to be ashamed of, that having a disorder and getting help. That is the thing, our responsibility. So depression or any kind of disorder we are human beings, we are not robots. So major depression is the one that we will be talking, which is a disorder, have been with us for long, as long as human beings have been around. So just to mention what are the depressive disorder, the mood disorder, and mood is a common word that we use every day. everybody, my mood is depressed, my mood is anxious, my mood is happy. That is not what we are talking about. When we are talking about mood in medical terminology, it is a prolonged emotion which colors your psychological life at least for 2 weeks. So it does not leave you, and it is a consistent kind of a mood disorder which is there with you, may leave you for 15, 20 minutes, half hour, but this is a consistent psychological emotion change, persistent, minimum 2 weeks. That's what the whole thing will be in the background, that whatsoever we are talking about. So mood disorder are depressive disorders. Those are major depressions. I will get to more specific what major depression. It could be single episode. It could be recurrent. Then there's a dysthymia. That is a very old terminology. If you see that, depression can be based on inner changes in the brain, or it could be associated with external forces. Old terminology up until 60s or 70s, that was known as a depressive neurosis, that there was a conflicts in our mind which was contributing to the neurosis. Now the terminology neurosis is not used. Freud used it, but I think it's well and alive in the field of psychiatry. We have to know that. And then if you cannot meet specific criteria for anything, the old terminology was depressive, not otherwise specified. When you cannot get anything together, there's a very nice category, not otherwise specified. And then bipolar disorder, you are familiar. It's the old terminology was manic depressive illness. One bipolar means there are two poles of the illness. One is high, and the other one is a depressed one. And the depressed one is in bipolar disorder. One can get cyclothymia, means going up and down very fast, up and down, high and low rapidly. And again, if you do not have a full criteria, bipolar, old terminology was not otherwise specified, but now in psychiatry and in medicine, it is bipolar type 2. So there's a bipolar 1, bipolar 2. Bipolar 2 is basically you get full-fledged depression, as will be talking, and there is not full manic episode, but a hypomanic episode. So that is just where we are today with the diagnosis and the terminology. For major depression, there are 9 major criteria. Out of 9, one has to have 5. But before you proceed with any of the criteria, you have to establish that there is a distinct mood change. As I mentioned earlier, there has to be a dysphoria, depression, depressed mood, change persistent for at least 2 weeks. And then out of these 9, 5 has to be present minimum, which means loss of interest, loss of pleasure, that is anhedonia. This is one thing I want to emphasize. Those of us who have never experienced any depression, we will not understand what it means. It is the most painful feeling that a human being can ever experience. Nobody knows what it means to have dysphoria. I have patients who say, I rather have a cancer, I have any disease rather than having this thing, and somebody has sucked life out of you and you don't know, nothing feels good, nobody, just the pleasure is gone completely. When I see patients, I tell them, I don't want to say I know how you feel, because this is a human reaction. I know how you feel. No, I don't know how it feels. I tell them, I know how to diagnose, I know how to treat, I know you will get better. But the pain, I do not understand what it is. Because lots of time when patients commit suicide, they do not want to kill themselves. They want to get rid of this agony and the internal pain that we have no idea what it means. I'm emphasizing that point. That is the first thing that has to have. And the worst thing anybody can tell to a depressed patient is be strong, pull yourself from the bootstrap. No. That tells I have no idea what I'm talking about. No, they are strong. Depression is not a weakness, it's a disorder, it's an illness. So pull yourself from the bootstrap, just be strong. Not just if you have a friend, if you have a family, these are the two things I will just totally leave. There is no strength or weakness associated with what we are discussing today. So after making a distinction that there's a depressed mood, there's a loss of interest, anhedonia. Weight loss, weight gain means changes in appetite. Loss of appetite, person does not want to eat. Food just does not taste. It is not that they want to eat, it is just horrible. Sometimes they force themselves to eat, as a result lose weight, but sometimes there is increase in appetite because of anxiety. You just want to satisfy your oral phase, which is not that common. But most of the time there is a loss of appetite associated with weight loss, mostly 10 pounds, 15 pounds, something like that. Insomnia or hypersomnia, as it indicates, loss of sleep. Loss of sleep is three types: initial, middle, and terminal. Falling asleep, that is difficult, mostly associated with anxiety, fear, what is going to happen, what if, what if, what if, and nobody has an answer for that what if. Middle insomnia, keep waking up, and terminal insomnia, waking up at 2 or 3 in the morning and cannot go back to sleep. That is mostly associated with major depression and associated, those are the patients will have hormonal changes that you can demonstrate with cortisol levels. So terminal insomnia is very typical of the major depression, which is very severe, that you don't sleep, you wake up 2 or 3 in the morning and cannot go back to sleep. And loss of sleep after night causes sleep deprivation that creates its own problem, as we know. Sometimes it becomes hypersomnia, patient is just sleeping too much because they cannot stand the pain and agony of the depression and they're just laying in bed, not moving. And next one is psychomotor agitation or retardation. The very important point, just the energy is gone, so person cannot move. It's just staying, cannot get out of the room, cannot get out of the house, psychomotor retardation. And psychomotor agitation is just wringing hand, just going agitated, and they are associated with different neurotransmitters. So one can make a distinction clinically what neurotransmitter is associated with retardation as well as with agitation, so you can select appropriate medication. So, but one of the symptom criteria is psychomotor agitation and retardation. Fatigue or loss of energy, another symptom. Feelings of worthlessness. This is the very, very important thing. I have no value, I'm no good to my family, I'm not good to my husband, I'm not good to I have created. And this thing can go to the extent of being psychotic. I can just say I have one person now who truly believes she should be dead because she has destroyed the universe, so she is worthless. So your mind really goes into the delusional state and poor concentration. You cannot focus on anything. This is the person, we give a book to read, person cannot concentrate on one sentence. What you are saying, mind is going from one area to another. And the last one is that suicidal thoughts are suicidal plans. That is because of the pain and the agony that the person is suffering, and it could be associated with feelings of guilt, which is mind is forming because of the depression. And guilt, when the guilt comes, guilt and punishment go hand in hand. Once the guilt is there, what do the society do with people who are found guilty? What's the final punishment we do to the guilt? We put them to death. Here, you're the prosecutor, you are the judge, you are the victim, you got the feelings of guilt, so you are going to kill yourself because you have committed sin and crime, which in reality does not exist. Your thought processes have changed. With the depression, there are three things going on. Your feelings, your thinking translates into behavior. Any question about the diagnostic criteria? Not? So these are the depression. Basically, this was the major depression that I was mentioning. Major depression could be one single episode. It is a recurrent disease. So there could be reoccurrences, relapses, or it may be associated with psychosis. If the psychosis is there, that is mostly associated with depression. Those hallucinations, if you're hearing any voices or seeing things, or if you are have a delusions, are colored with your psychological depression. By that I mean feelings of guilt associated with that. If anybody is hearing voices at that time, voices are continuously saying, you're a bad person, you have no right to be alive, you should be dead. And those hallucinations are very real. And so voices and the delusions are both congruent, negative, that associated with depression.
Could you take a minute and tell us what is meant by neurotransmission?
I'm coming to this.
Okay.
I went one slide ahead. Thanks. So it's a single episode, recurrent, associated with or without psychosis, major depression, dysthymia, which is a chronic depression going on regularly, at least for 2 years. Most of the time it starts in childhood and adolescent years, low grade, you can function with it. But many people may have a double depression. They have a low-grade depression, and periodically they get a major depression superimposed on this chronic depression. And that chronic depression, as I mentioned, it was known as depressive neurosis. Now we call it dysthymia, so it periodically gets worse. And all these things that I'm saying have a treatment implications as we gradually keep going with this one. And in the bipolar, I mentioned in the bipolar there could be a depressive episodes. Now we come to the etiology. What are the causes of depression? It's like anything in medicine. I'm not just saying for psychiatry. It is a biopsychosocial model. No matter what we are talking about, if we are talking about depression, or if we are talking about diabetes or high blood pressure, biopsychosocial model is there. But I'm looking at some of the biological factors. What is it? And historically, just very quickly, I will go over that biologically it is a biogenic amine hypothesis. I will explain a little bit more, which is associated with depression. And here I will mention one historical point. There is a drug known as reserpine. I think some of us physicians will know that, and other people in the school, when I ask them, they look at me, what am I talking about? Some foreign language, and there's a reason why I'm talking about it. Reserpine, it comes from Rauwolfia serpentina, snake root, and it was used for treatment of hypertension, known as Serpacil. Main thing is when reserpine was given to individual for treatment of depression, for treatment of hypertension, they become extremely depressed to the point suicidal. No pharmacological treatments were available at that time. They required ECT, very severe depression when you gave this drug, reserpine, for treatment of hypertension. Now, why am I talking about reserpine? There's a good reason. Rauwolfia serpentina, snake root, those of us who are from Pakistan or India, is neem. Neem. And the person who isolated the alkaloids from Rauwolfia, I would not be talking if I'm not going to mention his name, Salimuzzaman Siddiqui,
Oh.
chairman in the biochemistry department for University of Karachi. In 1939, he isolated reserpine from Rauwolfia. And the first alkaloid that he, which is not related here, but I'm going to say, he isolated from reserpine was edgemalene, because he was so impressed with the Hakim Ajmal Khan. So he first alkaloid of reserpine, he made edgemalene, and the politics of edgemalene and people how went after him, why are you doing it, is a different story. If you want to have fun, read that. But this was a pioneer. There will be no, he set the ground for today's neurological advances that we are looking in the neurochemistry or psychopharmacology, setting the stage for what we have today. He came very close to getting Nobel Prize, but he did not. But just read about Salimuzzaman Siddiqui from Karachi, biochemistry. That was a revolution in the neurosciences, that his discovery and what happened. So since there was a decrease, this drug was causing such a severe depression, which was just a pharmacological observation. Further studies were done which showed that reserpine depletes the neurotransmitters in the brain. And there are many neurotransmitters, but for today's discussion, basically there are three neurotransmitters I'm going to mention. One is norepinephrine, serotonin, and dopamine. Don't need to remember any of that. So it depletes. So that was the beginning of pharmacological observation, that the depletion of these neurotransmitters was causing such a severe depression. But in medicine, everything, when you see, you have to have a proof. So where is the proof? Then we look at so these are the two neurotransmitters I mentioned, norepinephrine and serotonin. So we look at the metabolism of these neurotransmitters, and metabolism of these neurotransmitters showed that there was decrease in norepinephrine metabolites that you can find in urine, and serotonin decrease, but the metabolites of serotonin you can find not in the urine, because a lot of serotonin comes from the guts or from other places. So you have to go in cerebrospinal fluid to see the level of the 5-hydroxytryptamines, the serotonin metabolite. So based on these two findings, what Salimuzzaman and his group showed, we are marching from just a clinical observation to the pharmacological observation to the biochemical evidence now, that how these neurotransmitters are associated with decrease and causing the symptoms of depression. This cartoon I'm going to skip. Just a simple kind of a cartoon on the other side, there's a presynaptic neuron, postsynaptic neuron. There is a micro space between the two neurons, which is your synaptic cleft. So this is the same thing, presynaptic neuron. In the brain, there are 100 billion cells. Sometimes there's a 10,000 synapses. So we have few trillion synapses. Weight of the brain is what? 1,336 gram in male, 1,200 grams in female. Less weight don't mean anything. We are just carrying unnecessary weight. So you can see what a big complex we are talking about here. How many synapses, trillions of them are there. So this is a very small part that we know in 2023 I'm presenting here. So there is tyrosine, don't need to know any of these names. The norepinephrine gets released into the synaptic cleft here. So it goes in the presynaptic neuron, the neurotransmission. One neuron is communicating with the other one. That's a neurotransmission, nothing more than that. In the presynaptic neuron, it's electrical impulse going on. When you see that gap, one neuron cannot talk to the other neuron directly, so they borrow the neurotransmitter to talk to the postsynaptic neuron, and that neurotransmitter could be either norepinephrine or serotonin or dopamine. That norepinephrine talks to the postsynaptic means beyond the synapse mean a gap, talks to the postsynaptic neuron, and further neurotransmission will take place. So what we saw in the beginning, that there was a decrease in the neurotransmitters and how to treat it. The treatment is to increase these neurotransmitters. So your antidepressants came, and that is what we are looking now is they are increasing your norepinephrine, they are increasing your dopamine, they are increasing your serotonin. So that is how so what we saw pharmacologically, biochemically, now we are going to the molecular psychiatry or molecular neurology. So the transmission is taking place, but it takes about, I'm just saying, if you take an antidepressant, any antidepressant, it will block the reuptake of the neurotransmitters. Because once a neurotransmitter is released, three things will happen. One, it will get destroyed right into the cleft. Second one is taken up back into the presynaptic neuron where it will be destroyed, or it will go and talk to the receptors in the postsynaptic neuron. Most of your antidepressants, as we will be coming to, block the reuptake of the neurotransmitters, so more is available in the cleft, and then that goes and continues with the new postsynaptic neuron. So if you give an antidepressant, it blocks the reuptake within 24 hours. But nobody gets better in 24 hours when you give them antidepressant. So the question comes, if the decrease is only associated with decrease of the neurotransmitters, people should be feeling better within 24 hours. After you take the Prozac, you should be better. It doesn't happen. Now we are moving from biological psychiatry to the molecular psychiatry. The postsynaptic receptors is associated with cyclic AMP, and you don't need to remember a single thing what I'm saying. Postsynaptic neuron is with the cyclic AMP, and cyclic AMP finally works with the Krebs, the cyclic AMP response element binding proteins, and that thing goes inside of the nucleus. I don't have the cartoon here, and that's where it interacts with the DNA, and that DNA changes the RNA. This is a messenger RNA. That messenger RNA comes out and produces new proteins and enzymes which are supposed to be lost in the depression. And it takes about 2 weeks, 3 weeks, or a month for that process to take place. So that is the mechanism which is happening. So really what I have moved into is into the nucleus, and in the nucleus there is the DNA. So we are moving into the genetics. Everything will end into genetics. So, but genes are not the only thing. There's the genetic, and then there's the epigenetic factors. So epigenetic factors are outside factor of a social life. How did we grow up? How did that affect the development of the brain? How did that affect the pruning, synaptogenesis? So I can go on and on that. But what I'm getting into is really the answer, the direction that we are moving into in the psychiatry, depression, schizophrenia, anything is going to go to the basically to our DNA and messenger RNA, and whatsoever defect was there. Now we see what DNA is there, what genes are there, which are responsible for serotonin, norepinephrine. So that is one part of the picture I'm talking about here. Since we are talking about the neurotransmitters, it is going to take us to the genetics. So everything is going to go to the gene. That's coming. I'm not talking about fiction. That's the direction we are going. Not just limited to psychiatry. I think in cancer, you see, lots of things have moved into the thing that I'm talking about. So I just don't want to go into too much detail about this. We can talk whole day about this. So we moved from pharmacological just a clinical observation to pharmacological observation to the biochemical to the molecular to the genetic. So in that direction it is going. And now if you go towards the treatment, again, what I said earlier, treatment is biopsychosocial model. It's a biopsychosocial, it's a 3-dimension, biological, psychological, social, and really for years, there's another dimension of treatment, biopsychosocial spiritual model. Very important aspect of the treatment, no matter what kind of treatment are you talking about. And so biopsychosocial spiritual model, as we were talking about, that there are depressions. It could be mild, it could be moderate, it could be severe. So treatment depends on the severity of the depression. If it's a mild, your psychotherapy can be very well. One can do that. So the treatment-wise is a psychotherapy, and it's not exclusive of the medication treatment. Combination treatment is the ideal and the best treatment. It is not either or. It is a combination of two things, your psychotherapy or counseling. There's a big difference between counseling and psychotherapy, but I'm not going to talk about that. And I will say somatic therapies. Somatic therapies we can divide into two. One is pharmacological and other one is non-pharmacological. Non-pharmacological treatment, I will mention and come back to that, is ECT and transcranial magnetic stimulation, TMS. So from pharmacological treatment, there are first generation, second generation, if you want to talk, antidepressant. The oldest one was your imipramine, again, an accidental discovery. Those are the tricyclic antidepressants. Wonderful medication, but they have a lot of side effects because all these antidepressants we are talking today, new or old, increase the neurotransmitters, or they affect the sensitivity of the receptors. That's why it takes that much time to changing the postsynaptic receptors. Basically, they get down-regulated when patient gets better. So, treatment-wise, if we go from the 50s, initial treatment was imipramine, which was an accidental. Everything was discovered in medicine accidentally. Then there were smart people who found out why this thing happened. So tofranil was the first one, which was treated for depression, imipramine, and then came the metabolite of imipramine. We just removed the methyl group, made it dizipramine, and that was an antidepressant. Then the next one was amitriptyline. We removed the methyl group, made it nortriptyline. What I'm getting into is for about 20 years, we were just Me Too drugs. We will either add a chlorine atom or an oxygen or take the methyl group and continue with the same tricyclic pharmaceutical. We just made a lot of advances in that way. But the side effects were there. Only one difference was, and that is still exists, that is where you really have to see what are you doing when you're giving the medication. Is this depression more associated with norepinephrine? Is that more associated with serotonin? Is this a low energy? That is where your clinical evaluation is so important to see and select as much as humanly possible the antidepressant. At the end, everything will meet together, whether you're with the serotonin, norepinephrine, and dopamine. But in the beginning, you can see that, which antidepressant is there. So, because we don't have any kind of other, we are getting there with the PET scans to see the activity and the information, because now we got the functional imaging to see that, but it is not available today for day-to-day clinical practice. So you have to really see it with your clinical judgment, because every patient is not going to respond to your pharmacological treatment. And that is a whole different topic, why there are non-responders. It's the selection of medication. It is somebody is getting rid of medication too fast. What is the genetic of metabolism, pharmacokinetic, pharmacodynamic? So there are a lot of factors goes on in the treatment, and those changes that we are looking today in the PET scans with the medication are associated with mild and moderate depression with the psychotherapy. So medication is there. The new antidepressant which came, and the Prozac was one which deviated from all the previous cyclic antidepressant was. It does the same thing, but it is more focused on one neurotransmitter, that is your serotonin. So previously, all the tricyclic antidepressants that we had, do I have time? All the previous antidepressants that we had will go and hit so many targets. Lot of side effects, dryness of mouth, arrhythmias, low blood pressure. So, because they were affecting too many neurotransmitters. And when the Prozac came, it just hits particularly serotonin. That's why we call it SSRI, serotonin reuptake inhibitor. So my own opinion is the old antidepressant for like a shotgun, you did that and it will hit many targets. And Prozac came, which is a laser which focuses on that. So you don't have the side effects of the previous one. So after Prozac, we are getting most of the SSRIs, but you have to remember that your SNRIs and your dopamine is very important. And there are Wellbutrin, which is a drug. I'm mentioning the trade names. Affects the dopamine. And there are other antidepressants which particularly affect the norepinephrine. So, and then there are still, everybody does not respond to that is where you have to see whether you need a combination therapy, whether you need augmentation, adding some, I'm using the terminology antipsychotic, but not for psychosis, adding another class of medication to make the antidepressant work better. And my analogy is adding those medications, you're really putting the accelerator a little bit more so that your car can move fast and you can get out of depression. Most of the treatment is outpatient, but serious depression, particularly suicidal, needs no ifs and buts. Inpatient is a life-saving treatment. In case of emergency, in this community, there's a crisis center, 419-904-2273, 24/7 in community mental health. It's available. There are community mental health centers, ZEF, Harbor, and Unison. And then there's a new national suicide line, 988, which is available. Anybody can call in case of crisis or anything. And, I think I will stop at that point.
So, summarize, if you will please, in a few minutes. Depression is common, it's treatable, and at the end, when you treat it, what is the success rate?
I have two answers for that. When it comes to one individual, it is either 0 or 100. After saying that, it's not very exciting thing I'm saying. 40% people will respond to antidepressant first time. Then you continue with that. And after that, the treatment you have to go adding augmentation, combination, so the rate will go high. I cannot say again 100%, but it will go to 60-70%. And the severe cases, which point that I did not mention, is when it's a severe major depression. ECT is a lifesaver treatment.
Tell us what ECT is.
ECT is electroconvulsive therapy. Like anything else in medicine, discovered accidentally in 1935 by two Italian guys, Cerletti and Bini, accidentally in the asylums at that time. Those individuals who were there, if they have epilepsy seizures, then some of their symptoms got better. So based on that, these two psychiatrists said, why don't we find a method to induce seizures? So that's how they were chemically, seizures were induced with camphor and metrazole, and electrically with, when we talk about electrically, I'm not talking about watts and volts, I'm talking about 90 joules. One thing that One Flew Over the Cuckoo's Nest movie did such a disservice, but his goal was to get the Oscar and Academy Prize. If he was not dramatizing, he won't get the prize. That has nothing to do what you saw in the movie. Nothing. I do it, I'm going to do tomorrow morning, I do it on Friday. There is no jerking, jumping, anything. We just monitor the EEG, how long the seizure was there, and it is a life-saving oldest treatment from 1935 that you give. But it's a lifesaver, lifesaver, lifesaver.
So it's electroshock treatment where you shock the brain with electricity.
It is with that, but it is in joules.
Yeah.
It is in joules. It is nothing. I forgot the name of the actor. It flew.
Jack Nicholson.
Thank God I forgot. So.
Nurse Ratchet.
Nurse Ratchet.
Yes.
First of all, a very comprehensive discussion.
Okay.
My question is that if we, in our practice as a general practitioner interns, if you have a mild depression, it can respond to SSRIs or Prozac and other drugs. But if it's a major depression, you really have to give Wellbutrin and plus small dose of antipsychotics. That's the people I see. Because patients can be on SRI for years, like 2, 3 years, but they're still depressed. They never really pull out of it. So I think the biggest mistake is we as practitioners keep them on a smaller dose of SSRIs too long. That's what.
I 100% agree. My other analogy will be if patient has pneumonia and you give him 50 milligrams of penicillin, it's not going to do the job. You have to give the optimum dose. Less is not good, high is not good, optimum. That is what we want. But after saying that, everybody has different metabolism. If somebody is ultra rapid metabolism, I can take 150 milligrams of Zoloft and may not have any Zoloft in my system because my cytochromes are just chewing it up like nothing. On the other hand, there are patients who take 10 milligrams of Paxil and they have a side effects. Then you give them small dose of another one, they have side effects, and we declare them playing games. No, he's an ultra slow metabolizer. The 5 milligram of homeopathic dose is causing such a high level that she is having a side effects. So we have to do that. For some of the psychotropics, we have a therapeutic window. Less is not good, higher is not good, therapeutic window. But we do not have, we stopped that research, unfortunately, in the 80s of the plasma levels. Now you have a study with the cytochromes, the P450, to show how it is metabolized. But that is more confusing today than really it's help. You exactly have to know what you're doing, not just swabbing your nose. Yes, sir.
Just a general question. Is it true, this statement is true, that most of us, or maybe all of us, have some level of depression, but it differs from one person to another, just like cancer cells. The majority of us have cancer cells, but it differs from one body to another. Is that true?
Having a clinical depression, everybody knows. Do we feel sometimes down and we call it a depression because of the external event? Yes. That is the point I was making earlier. That is the human feeling anxious is a normal part of life. Feeling somewhat down, something happens, it's normal part of life. But the clinical depression that I was discussing, not, I will say no to that. But 10 to 20% have, it may be very low-grade depression going on, which can be treated with psychotherapy and medication.
What do you recommend for somebody who resists treatment? What kind of method do you recommend to convince somebody who has a severe depression, but sometimes rejects treatment or seeing a specialist as you?
That is such a common thing that we see most of the time. In the emergency room, the police brings the person, both arms slit, and the person is saying, I don't need treatment, we have to go to court, we have to commit them. This is not a single answer. Most of the time, what I try to do is find somebody, a friend or a relative of a family member, having an approach. It changes from person to person. And somebody has to say, okay, you are not depressed, nothing, do it for me. Just do me a favor to do that. I'm not saying you're depressed, I'm not saying anything. Please, would you do it? Other one is, there are many different ways of it. There's not one single answer I can have. Plus, the most important thing what you're saying, when you're depressed, you are the person who don't see I'm depressed. It is like, again, this is my personal example, looking through a green glass. When you look through that, everything is green. Everything is hopeless. Nothing is going to help. Nothing makes sense. He's not. It is absolute looking through a green glass. With the treatment, when you remove that green glass, you see the true colors. Then you see what people are saying and doing. Just now I have a person like that and using with the ECT. At that time, your judgment is gone. It is other example is when you have appendicitis, you get pain right lower quadrant. When you are depressed, your thinking is changed.
Dr. Majubin has a question.
So
Yes.
I get the biologic model of depression. I had a patient who was an accountant, and I asked him how, when he noticed depression. He said, I think I was in kindergarten. So that's very explicit. But my question is that someone who does not have a depression and they reach like adulthood and they have a major life trauma and thereafter they have a depression, how do you explain, like, is there a neurotransmitter imbalance that happens that causes that? Is that correct?
Yes,
Okay.
very, very clear, yes.
Okay.
Now, there's a possibility, there are two things. Similar kind of trauma another person experiences and does not go to deep depression, major depression.
Right.
What are the protective factors and what are the factors which did that? That really takes us to the research where we are going today. When the brain is developing, how the past experiences affected the development of your frontal, a whole different topic I'm talking, how the pathways were arranged, how you got more vulnerable to a trauma that the next man feels sad and unhappy for 2 or 3 days and is out, and the other one is down into the depression. That's the genetic factors.
So, final question. Is the treatment for life or short term?
First episode, single episode, I will go for 2, 3 years, then continue to follow. But if it's more than one, it is not worth going through the episodes again and again. So, like a hypertension, I have to take the lisinopril. What can I do?
Well, understand that for hypertension, you can measure the blood pressure. You cannot put a blood pressure around your neck to find what's happening in the head. So, what you're saying is that once you have a moderate to severe depression, then you're committed to have the treatment for life. Am I right? saying that?
I'm telling that few people will not believe it. They will stop it. They will have a relapse.
Yep.
So 2 or 3 relapses, then they say yes. But if you're asking, should they continue? What I know today, yes, you should continue.
I think Dr. Shahid gave us a very comprehensive.
Excellent.
I thank him. Even I understood what he was talking about.
I did not.
We'll go for Zohar. Thank you.